Hello, my name is Joshua Sixon. I'm a second-year internal medicine resident at JFK Medical Center in West Palm Beach, here to discuss a case of pulmonary embolism in a patient with undiagnosed hyperthyroidism. The symptoms of hyperthyroidism that were typically taught in medical school and encountered in clinical practice include excessive sweating, heat intolerance, tachycardia, and hyperdefecation, essentially things related to increased metabolic rate. There are studies that suggest that hyperthyroidism also promotes a prothrombotic state and may be linked to development of venous thromboembolism and pulmonary embolism. Here is a case of a 61-year-old woman who presented with pulmonary embolism that I encountered while I was on the medical floors, who was eventually diagnosed with Graves' disease. So this is a 61-year-old woman with osteopenia who presented with 3-week history of non-productive cough, shortness of breath, nausea, chills, night sweats, myalgia, fatigue, tremor in the extremities, intermittent watery diarrhea, and a 15-pound weight loss. The patient actually presented 2 weeks prior to our clinic with the main complaint of cough, shortness of breath, and fatigue. Those are her main concerns at the time. Influenza A rapid molecular assay was done, which was shown to be positive, and she was treated with oseltamivir with no improvement. She returned to our clinic 2 weeks later with the same complaints and was then found to be hypotensive and tachycardic. So she was transferred to the emergency department where she was given IV fluids. Her blood pressure did improve with fluids, but she remained tachycardic. Further workup from there included plasma D-dimer, which was elevated, and overnight she underwent CT angiogram, which showed bilateral submassive pulmonary emboli. A transthoracic echocardiogram was also done, which showed no evidence of right heart strain. So the patient was started on IV heparin, but she remained tachycardic. The next day, further workup included thyroid stimulating hormone, which was undetectable, less than 0.015, as well as free T3 and free T4, which were both elevated. CT abdomen and pelvis was also done to assess for other potential causes for unprovoked PE, which was negative for her. While inpatient, the patient was started on low-dose atenolol for management of her symptoms and transitioned to oral apixaban for discharge. In the outpatient setting, she also got testing for thyroid-stimulating immunoglobulin, which was elevated, as well as a thyroid ultrasound, which showed heterogeneous thyroid and multiple nodules in both lobes. With the diagnosis of Graves' disease, she was started on methimazole and improved symptomatically in the outpatient setting. In the center of the slide, you'll see 2 pertinent imaging studies for our case. The first one being the CT angiogram, and here it demonstrates the bilateral pulmonary emboli, the right being more prominent. The second image is the thyroid ultrasound. Here it shows the largest nodule, which was on the left. So this case demonstrates the potential role that hyperthyroidism plays in the development of VTE, which has been described previously in the literature. So far, the mechanism is poorly understood, but one meta-analysis I came across showed an association between elevated serum thyroid hormone and an increase in factors 8 and 9, von Willebrand factor, and fibrinogen. One learning point for me from this case was, in our patient, after uncovering PE, an important step would be assessing for potential causes of unprovoked PE. For her, that included the CT of the abdomen and pelvis, which was negative, as well as going back to the history and making sure she's up to date on age-appropriate cancer screenings, including mammogram, colonoscopy, and cervical cytology, which she was. In conclusion, our study emphasizes the need for evaluation for hyperthyroidism in patients with unprovoked venous thromboembolic events, or at least the importance of keeping it in mind in the differential when working up potential causes for unprovoked PE. In general, further research is required to better understand the clinical implications and approach to patients with hyperthyroidism and their risk for future thromboembolic events. Thank you.